Hello, my name is Kayla Rausch, and I will be giving a presentation on neuroblastomas. So here's some anatomy and physiology background on the adrenal glands, which play a role in neuroblastomas. So the adrenal glands sit on top of the kidneys. They're also known as the suprarenal glands, and they're a small triangular shape. So they're these right here. You can see the little triangular shape that they have. They're composed of two distinct tissues. So the outer cortex is this fattier yellow tissue right here. And then the inner medulla is this reddish brown color in here. They make many hormones that help regulate metabolism, immune system, blood pressure, and then response to stress and other essential functions. So they help to make cortisol, aldosterone, adrenaline, and different things like that. So continuing on with the A and P, this is considered a cancer commonly found in the adrenal glands. Again, those are the small glands on top of the kidneys. Again, this is a picture that is of a child. It can develop in the belly, chest, neck, pelvis, and bones. Usually children ages 5 and younger are most commonly affected by neuroblastomas. There may be a lump or compression of tissue in the affected area. And some symptoms in children include fatigue, loss of appetite, and fever. Some background on neuroblastoma. So it is a cancer that forms in neuroblasts in the adrenal glands, neck, chest, or spinal cord. A neuroblast can be considered an immature nerve cell. And again, they most commonly arise on the adrenal glands of the kidneys. Some certain genetic conditions that affect the risk of having neuroblastomas are Costello syndrome, neurofibromatosis type 1, and if you have pheochromocytoma or paraganglioma syndromes. Some tests that you can use to diagnose a neuroblastoma are your urine catecholamine tests or studies, blood chemistry, MIBG scans, CT scans, MRIs with gadolinium, a PET scan, an x-ray of the chest or bone, an ultrasound, or even a biopsy. Some different signs and symptoms people may experience are lumps in the abdomen, neck, or chest, bone pain. Infants may have a swollen stomach and trouble breathing. We can have bulging eyes, dark circles around the eyes that look like black eyes. Also in infants, we can have painless bluish lips under the skin. We can have weakness or paralysis, fever, shortness of breath, petechiae of the skin, and something called Horner syndrome, which includes droopy eyelids, smaller pupils, and less sweating on one side of the face. There are different stages of neuroblastomas. So there's stage L1, L2, M, and MS. Stage L1 is when the cancer is only in one area and there are no image-defined risk factors or IDRFs. This would be something found on an MRI or a CT, and it's used to help determine the risk of surgery and the chance of completely removing the tumor. Stage L2, the cancer is still in one area, but it has not spread beyond any nearby tissue, and this has one or more IDRFs. Stage M is when the neuroblastoma has spread far from the original tumor, and stage MS is usually in children younger than 18 months old, and they have cancer that has spread to the skin, liver, and or bone marrow. Some different radiopharmaceuticals that you can use for imaging are I-123 MIBG and technetium-99 MMDP. So I-123 has a half-life of 13 hours with 159 gamma keV. You usually administer this through the IV. It's supplied in a liquid form and stored in a frozen vial. Technetium 99M is also known as methylene diphosphonate. There's a half-life of 6 hours, a 140 keV gamma, and this is also administered through the IV. And this is usually stored in something called a shake and bake kit. So some preparation for I-123, you're going to want to thaw the vial at room temperature in a lead pot. Make sure not to overheat or refreeze this vial. And you're going to confirm complete thawing of this vial, and then make sure to gently swirl to ensure the homogeneity of the mixture as well. Then we're going to insert a venting unit to avoid pressurizing the contents of the vial during dilution. And this venting unit consists of a needle, 0.2 micron sterile filter, and a charcoal filter. Then we're going to add a sufficient volume of 0.9% sodium chloride solution, USP, to the vial to yield a concentration of 1 millicurie per milliliter. Then we're going to draw the dosimetric dose into a 10 milliliter shielded syringe, and then we're going to place that dose in the dose calibrator to ensure that the activity is within plus or minus 10% of the dose. And then make sure to maintain this dose at room temperature, and that we're also administering within the 8 hours of retrieval from frozen storage. So then I went and researched a case study on neuroblastomas. So here's some patient history of the case. So we have an 8-month-old female that was admitted for URI problems. She has a palpable mass in the right upper quadrant that was found upon physical examination. She was admitted with preoperative diagnosis of the right upper quadrant mass consistent with a neuroblastoma versus Wilms tumor. Again, a neuroblastoma is a cancer that develops from immature nerve cells found in several areas of the body, and it most commonly occurs in infants and young children. She was then taken to the operating room. The mass was found to be unresectable, so they did an excisional biopsy and obtained that, and the mass was ultimately determined to be a neuroblastoma. So this was determined by pathology in urine catecholamines, as well as classical appearances on multiple imaging studies. So as I said previously, urine catecholamines is a big way to determine a diagnosis, and then also imaging modalities in studies such as CT, ultrasound, MRI, etc. Now we're going to go into those imaging tests that were performed and the different findings for them. So first there is a CT scan, and on that CT scan they found a large heterogeneously enhancing mass within the right, mid, and upper abdomen. There were several regions of calcification within that mass. They found an intact right renal cortex. The mass exerted comprehensive mass effect on the right kidney and liver. The mass extends across the midline, displacing the portal vein to the left. The liver is compressed, but otherwise it seems to appear normal. There were no other masses or abnormally enlarged lymph nodes seen within the abdomen or pelvis on the CT scan. The ultrasound then found a large right upper quadrant mass inferior to the liver, displacing the right kidney inferiorly, consistent with the findings in the CT scan. Adjacent to the mass, the inferior vena cava was compressed without obvious thrombus. The inferiorly displaced right kidney measured to be 6.9 centimeters, while the left kidney measured 6 centimeters longitudinally. Then moving on to the bone scintigraphy, there was found to be an uptake of the radiopharmaceutical in the large right-sided abdominal mass, extending to the midline, correlating with the mass seen on the CT scan. There seemed to be no other areas of increased uptake in the skeletal system to suggest osseous metastatic disease, but it was noted in the findings that an MIBG scintigraphy would be more sensitive for detection of the metastatic disease due to a neuroblastoma. So with that being said, they followed through and did an MIBG scintigraphy study, and it found markedly increased MIBG activity in the right paraspinal region in a triangular configuration corresponding to a portion of the mass seen on the CT scan. So if you noted previously in our A&P background, I stated that the adrenal glands are a triangular shape on top of the kidneys. So being that it's stated that the paraspinal region, there was a triangular configuration, we can correlate that with our adrenal glands. So inferior to that triangular area would be a small focus of activity. This could be in the mass, or it could also be an adjacent lymph node from the mass. With the mass being smaller than the mass seen in the bone scan, this suggests that there's a type of necrosis present in the tumor. Additionally, there was some focus possibly representing a metastasis seen in the region of the left frontal bone. So the abnormal focus in the region of the left frontal bone may involve the orbital. There is an area of very subtle increased activity along the left frontal bone when going back and reviewing the bone scintigraphy. So the following are going to be the images from the tests that we just talked about. So here's the ultrasound. You can see that some things look a little darker in areas. And then the CT scan here. And then next we have our bone scintigraphy here. And over here we have our MIBG scan. You can see areas here that are a little brighter, meaning that they have some uptake in them. So finally, we're going to go through the major focus of the case study. So the major focus of that study was the differential diagnosis for retroperitoneal masses in the adrenal renal region for children, which includes neuroblastomas and Wilms tumors. So a Wilms tumor typically doesn't calcify and would have no uptake on a bone scan due to the absent calcification. It also wouldn't have any uptake on an MIBG scan either. So this shows that the tumor diagnosis is a neuroblastoma over a Wilms tumor, because if you saw previously, we mentioned that there was calcification in this mass, and it did have uptake during the bone scan and the MIBG scan. So this is an obvious neuroblastoma over Wilms tumor. So thank you guys for following along with me today. I hope I was able to teach you a little bit more about neuroblastomas. If you have any questions, please feel free to reach out. Again, thank you for your time and following along with me.